All right, so I'm going to show you the PowerPoint that I did in class. There was an issue with recording, so I'm just going to make sure I go over it here. This is a picture that we talked about that has the kind of default beats per minute for the AV node, the SA node, and some of the other conduction pathways. We're going to talk about the ventricular rhythms. So, unlike the atrial rhythms, when the ventricular rhythms are affecting that bottom part of the heart, it's going to affect the cardiac output. So, without having an organized rhythm and a QRS that is going to make sure that we have a nice, steady, regular rhythm, we're going to affect cardiac output and tissue perfusion, right? So that blood's not getting where it needs to be. So if you look at this tally strip here, you can see there are two black arrows pointing to QRS complexes that are very wide. Okay, that has to do with a delay and the amount of time it takes to get through from the AV node through to the left ventricle. So from the right side all the way around to the left. And when that starts to take longer, then we're going a little bit wider because that's the length of time. So all of us have had PVCs from time to time. Maybe like people that say their heart skips a beat, right? Kind of a flaring in the chest, kind of asymptomatic. You're not, and it's not impacting your cardiac output. Everything's still blood still circulating, but it's just an early beat or an extra beat, right? Sometimes if they happen very frequently, we can medicate them with some beta blockers or something to kind of keep that down. Or we can actually do an ablation where they go in and they kind of cauterize an area of the heart that maybe is generating these. But overall, not a big deal. We've had them from time to time. Where it becomes a big deal is when we start doing multiple ones in a row, right? So two in a row, we call a couplet. Three in a row, we call the triplet. And this is where we want to start paying attention. When we document, we can have normal sinus rhythm with a couplet, right? Or a PVC. When they start occurring frequently enough that you can time them out every other beat, every third beat, then we start looking at a different rhythm called bigeminy or trigeminy, quadgeminy. But we definitely want to keep an eye on it because occasional PVCs are nothing that we're concerned about. But when they start to stack together, then we start to look at maybe we're getting toward a VTach or a ventricular tachycardia, where it's not waiting for the SA node to give it its conduction. It's actually starting to do it on its own. So when you have a PVC, if you look on this strip here, you have one, the first one and the third one are one direction, and when that one in the middle is an opposite. So if they all look the same, then we call it a monomorphic or a unifocal. Okay, it comes from one spot in the heart. But if we start to have different shapes of PVCs, then we know it's coming from different places too, right? So that's something we need to look at. Is this one area that's affected, or is it multiple places that are having some problems? If it is, starting to really be recurrent, right? If we notice that it was one every once in a while, then it goes to a triplet, then it goes to trigeminy, right? Then we know that that heart muscle is getting oversensitive, it's getting irritated, and we wanna keep an eye on that because, while it might be nothing, it also could indicate that there's a risk of something more, lethal that it might be on the horizon. So we definitely wanna keep a look at this. If you have a patient that is exposed to toxins, if they're taking alcohol, caffeine, if they're doing different cold medications, if they're doing Celsius drinks, something like that, electrical light imbalances, all these things can cause PVC. So many times it's we have to find the cause, and then that's the treatment itself is eliminating whatever is causing the irritation. But if it starts to happen more frequently, right, then we know that that myocardium, that those heart muscle cells are really starting to get irritated. So these five things here are all indications that we need to start paying more attention, right? So if you started with a PVC and now they're becoming more frequent, you're getting six per minute, you're starting to see them different types. Um, it's falling where it shouldn't, right? Maybe it's falling on the T wave. Or if you have a patient that is within a couple hours of having an MI, right, myocardial infarction, and they're starting to develop PVCs, right? So these are when you get report on your patients. If any of these things are happening, you need to move them up to the priority list, right? Those are the people that you're going to go and assess pretty quickly. PVCs are very wide. PACs are very narrow. They both come early. They both can be in the middle of a perfectly healthy sinus rhythm. But when they come early, if it's wide, it's a PVC. If it's narrow, it's a PAC. There is something as a premature ventricular contraction that is junctional. We're not going to go there, but I like the slide. If we know that that electrical activity is getting there, and if we know that there is a history of scar tissue, muscle damage, a dead spot in the heart, something like that, that's where we get into these blocks or the conduction disturbance. And we call them a block because the electrical activity has to kind of reroute around a spot that might be dead or might have scar tissue or might have some type of a unreactive spot in it. And so it takes a minute to kind of go around that little detour. And that's where we end up with a shape of the QRS that's different. So a widened one, we always think ventricular anyway, right? If it's wide, we think there's something going on in the ventricle. But if it's wide with a real distinctive shape, then we think it could be a heart block. Okay. So there's three types that we want to know. The first is AV block, right? First degree AV block. The second is second degree AV block, and there's two different types. And then third degree AV block, okay? So these are there's actually four, right? Because there's two second degree blocks. But does it have to do with the PR interval? Does it have to do with the P wave, or does it have to do with none of the above? Okay. So our first degree, if you look on this slide or on this strip, you'll see that from the P wave till you get to the QRS is a little bit longer. Very consistent, still a regular rhythm. All the pieces are there, the P, the QRS, the T. It's just a really bit longer, right? Over 0.20, I believe, to get from the P to the QRS. Very asymptomatic, usually causes no problems. If for some reason it is causing a bradycardia, you can treat it that way. But really not anything that we are overly concerned about. Many people have no idea that they have it. Again, it's the least severe block that we're worried about. Everything is still getting there. It's just taking a little bit longer, right? So we treat it like sinus bradycardia. When we get into something like this is a Mobitz type 1, okay? And when we're taking a look at this strip, we have our P and our QRS. Look at that first beat, everything looks great. You look at the second beat, and again, we get that longer PR interval. Then you look at the third beat, and you have a P wave in a pretty long spot to get to the QRS. And it keeps lengthening until you look at right after that fourth beat, you have a P wave and then nothing. Okay, so it has taken so long to get where it needs to be that the ventricle's like, forget it, I'll get it on the next go around, and we'll go and we'll start this over again. So sometimes this is symptomatic, a lot of times it isn't. It may feel like a skipped beat, or it may feel like a fluttering sensation. But what this is it is a longer PR interval. And then eventually it just drops, right? So the P wave causes a contraction, the P wave causes a contraction, the P wave, forget it. We'll get the next one, P wave, and then it beats again. So the longer drop is what we call a Winky Bach, which is a type 1, okay? And this doesn't usually cause any problems, but it's something that we need to be aware of. Okay, so when you look at the tele strip, that's what you get. If you're looking at it and you're like, well, there's a P wave, there's a QRS, but then there's a P wave with nothing after it, but it doesn't look like it's getting longer, then we have a second degree, right, which is a type 2. And that is just, again, there's no lengthening. It's just the PR interval is the same. And then all of a sudden, like, whoop, the ventricle forgot to respond to that. And so we have that little gap, and then it starts over again. We treat the underlying cause if there is any. We can treat it like a bradycardia. Sometimes we see this in MIs, but if the P's don't get through, then you have a Mobitz too. That's how kind of remember that one. So not all the P waves have a QRS complex behind them. Our third degree is where these get interesting. Now, if you look at this, it has lots of asterisks and it says very, very symptomatic. So if you look at those P waves, boom, 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 they're very regular. If you look at the QRS complexes, boom, 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 they are irregular. They are very regular as well. But you look at the two and they're not lining up. So if you look at this person's heart rate, it's going to be 30, right? Their pulse rate is going to be 30. 30 is not sustainable for very long, right? But the SA node thinks it's firing just fine. and the QRS complex is firing in a very regular rhythm just fine, but they're not talking to each other at all. And this is going to be very symptomatic. You're going to be syncopal. You're going to have dizziness. You're going to have shortness of breath. And we have got to pace this. We have got to get this under control and get everything synced back up, or they're not going to be very healthy or very long. That cardiac output cannot sustain with third degree block. We have to do something. And so that's where that first picture I showed you, where the SA node goes a certain amount, a rate, and the AB node can go to a certain rate. Both of them are at their default settings. They're just not talking to each other at all. And so we have to make sure that we take care of this. Okay. If we have a block, okay, so we talked about those three types, right? Those AB blocks. If we have a block that is a widened QRS complex, so it's taking a little more slowly to get through, um, and it looks kind of funky, right? So it's widened. We know that there's a block in there somewhere. Okay, so we have to decide where it's coming from. So is it coming from the right side or the left side? And so what this is an area that is damaged, that is scar tissue, that is muscle that's not healthy, and that electrical conduction has to take a detour and then go through the ventricle. It's going to cause a delay. And that's where we have that widening. Most commonly, you're going to see a right bundle branch block somewhere in the right, and it's going to get through to the left. Okay. It's going to get there. It's just going to look a little funky. So if you look on here, you see kind of this like notched. Right here, you see a notch. Right here, you see kind of a notch. See how it kind of goes up and then out at an angle. We call that a right bundle branch block. And this is what you're going to see when you hook up somebody who's, a 60-year-old smoker, truck driver, whoever, who probably has not had some good primary care, and you put them on the telemetry, and you're going to see a little bit widened QRS, and you're going to see kind of a funky shape, and you're going to say, "Did you have any heart problems?" And they'll say, "I don't think so." Your heart is telling you otherwise, right? Your heart is telling you there's something going on there in the past or maybe currently, but there's something happening, even if they don't know about it, right? So they got that little notched appearance. Okay. If that little scar tissue, deadened area happens on the left side, it's not nearly as common, but it is much more severe, right? It has much more because think about it, that left side of the heart that's the last stop. It goes from there out into the body circulation, up to the aorta and out to the body. So if something is happening where we have that dead spot in the left ventricle, we're going to have a worse outcome, right? Because it's going to make it harder to pump. And what that's going to look like is actually little bunny ears, right? So if you look at this big notch here and this big notch here, it's wide and then it's notched. Okay, so you're going to see this with your STEMI patients, right? With your MI patients, with ischemia patients. It's very wide, very notched. And again, that's going to affect your cardiac output and your perfusion. If it can't get through the ventricle can get the blood to the body. Okay, this next group of rhythms we're going to call our lethal arrhythmias, right? Because if left untreated, they are not compatible with life for very long. So this first one is called an idioventricular. If you look at that, it probably couldn't sprace out much further, right? It is so stretched. We don't see a P wave. We see a rate of here, we've got about a rate of 40. And a lot of times we'll see this when the cardiac muscle is very irritated. It is not responding well. And what we do with that then is we have to get medications such as amiodarone or lidocaine, which are anti-arrhythmic, anti-inflammatory. We get our heart muscle less excited, right? We decrease the excitability of it, and we try to get that a little more close together and get it a little more organized, because it's stretching out to the point where it's almost not doing what it needs to do. Okay. You're going to feel pretty cruddy. Sometimes I don't feel it, but left 40 beats a minute with this wide of a rhythm for that very long, eventually you are going to. Okay. Usually the rate is less than 50. We don't see those P waves. Like I said, it's going to get wide. Okay. If it gets wider and longer with a pause in between, if it goes below 20, we call that agonal. We have agonal breathing, where they just take a breath instinctively 4 to 6 times a minute. It doesn't mean it's breathing. A heart rate of an agonal rhythm that is 20 beats or less, that's really not compatible with life. So we treat this the same as asystole. If your patient has gotten to this point, we are doing CPR. We are doing interventions, because you're not perfusing the brain and other organs at this point. If you have the opposite, if you have a tachycardia, so this is where the ventricle is pumping very, very quickly. And over time, what happens is it can sustain for a while, but eventually there's no fill time, right? And so if there's no blood being pumped out, even if the heart's moving, we're not going to be able to sustain cardiac output. So there's three different kinds here that you'll see. All of them are ventricular tachycardia. They can or cannot have a pulse with this. So if you look at the top one, those look sort of like PVCs, right? They're extra beats. You can do that for a little while, right? So you can still fill for a little while, but over time, if this is sustained, again, it's going to run out of blood in that ventricle and it's not going to have anything to pump out. And so you lose your pulse. So the first thing you want to do if you have any type of ventricular tachycardia, you're going to make sure you have a pulse. Super important. It can do that for a couple beats in a row, right? And we call that we call it a run, a short burst, couple in a row, or it can be sustained, and that's where your whole rhythm or your whole monitor screen is going to fill up with those. Okay, usually it's pretty regular. It's going to look regular, whether or not the pulse is regular. Most often, this is going to come from an MI. So I had a friend that came into the ER, came at about 2 o'clock in the morning. He was just having some chest pain and he was concerned. He had a strong family history. So we hooked him up to the monitor, and sure enough, like it looked like he was having some cardiac injury happening. And so we were talking and hooking him up and talking about his son and getting his phone number so I could call his son. And he went into VTAC that quickly because it is just once that muscle starts to get damaged, then the conduction system gets completely disrupted and it can go very quickly into VTAC. Okay. It could be proximal, and that's what we call where it pops into it and then it pops back out intermittently, right? So you might be getting concerned and like, oh, look at that. It goes back into a normal sinus rhythm. And it can do that back and forth as long as we have some cardiac output, as long as it goes back to a sinus rhythm or some type of a regular rhythm where we have good contractility of the heart, we've got an organized rhythm, and then it'll go back. So we definitely need to make sure that we are acting on this. Again, may or may not have a pulse, but if it's sustained, it's not going to have a pulse for very long because we're going to have poor cardiac output, we're going to have hypotension, and then we're going to have no pulse and loss of consciousness. Okay. There's different kinds. So if you look at this first one, they all look the same, right? Monomorphic, they look the same, just like with the PVCs, right? They all come from the same area. We have polymorphic, and that's where it's coming from different areas where it's really starting to get from different areas of the heart. And again, it doesn't matter what it looks like. If it is VTAC, if it's a wide rhythm that doesn't look like it's gonna pop out of it anytime soon, we intervene. This third type of VTAC is actually a special kind. It's called torsades. And if you take like a crepe paper and you twist it, and you know, it kind of like does one of these, that's what it looks like. A lot of times this starts looking like this and then progresses very quickly to VFib. And the treatment with torsades is always magnesium. So this is mostly electrical imbalance. So it is VTAC, still VTAC, but we treat it a little bit differently than we do the other two because there's usually an underlying cause of an electrolyte disturbance. Either way, what we want to do with any of these rhythms that we've talked about all day long, right? Between whether it's the sinus, whether it's attack, whether it's whatever. If that electrical energy is disorganized, right? We're not talking about like third degree heart block where everything's doing its own thing. If it this is BFib, AFib, right? Flutters. That's how we get a clot, risk for stroke. If the ventricle flutters, okay, we have no cardiac output. There is nothing organized, nothing is pumping, nothing's pumping at the wrong time because it's not pumping at all. This is where we have no pulse. This is where we are doing CPR, right? Our goal is to intervene though while we have that VFib because we still have electricity, right? We still have something. And our goal is to try to get that into something that has a QRS so that heart can pump again. If we don't reestablish that, it is very quickly going to go downhill. Okay, so our best chance of survival is early identification, early treatment up until this point. And our best chance of successful treatment is to reorganize that rhythm by shocking or defibrillation. Because at this point, there's no cardiac output. This is considered cardiac arrest. Okay, and I had students argue with me and say, no, it's not cardiac arrest because there's still electrical activity. doesn't matter, right? We are not having cardiac output, it is cardiac arrest, and we are doing CPR. Okay. So we have about 4 minutes, and after that, the brain is not going to perfuse. We have course, right? And that tells us that the electrical system is there. When it gets to fine, we know that it's lessening, right? The amount of electricity in that heart is really not doing what it's supposed to do, and we're losing it. It's not asystole yet. We still have something. We're still going to keep going. And then when it does get it to asystole, it's very difficult to get the heart to restart a conduction when there isn't any. If there's something there, we can work with it. If there's nothing, it's very difficult for us to have a successful outcome. Okay. The last thing I want you to think about is your assessment of your patient, right? It doesn't matter what is on the monitor, you have to look at the patient, right? Because this looks like a very nice rhythm. It's a little wide, right? But it's nice and regular. We have a rate of 40. But if I take a pulse on my patient and I can't hear one, I can't feel one, this is then treated as asystole because the conduction is organized, it looks beautiful, but the heart is not responding. And this is again something that's very difficult to treat because if we have something, even if the muscle's quivering, we need something. But once it stops, then we are not very successful at all. So when you're reading your test questions or your ACLS book questions and it says, here's your rhythm strip, I don't care what it looks like, something organized. And then it says the patient has no pulse. You don't even need to march anything out. You don't have to space it out. You don't have to count it. It's automatically PEA, pulseless. Okay. So just remember that anything that looks like you want to start counting it, measuring it, and all that, but if anywhere it says the patient has no pulse, we treat it as asystole and we continue on. Okay. So we are going to dive into these more. We're going to get some hands on with this, but just to give you an idea of, we have our sinus rhythms, we have our atrial rhythms, we've got our ventricular rhythms, we've got our lethal rhythms. So just kind of in your head, kind of have an idea of, is it regular or is it irregular? Okay. Are there extra beats or all the beats there accounted for? Is it wide? Is it narrow? How fast is it? Right. These are all the things. And then, of course, we're assessing our patient. Is there a pulse? Right? Does the pulse match what we have on our monitor? These are all the things that we're going to look at. So, more than memorizing rhythms, we want to kind of understand what goes on behind them. And also in your module, in your week lab module, or I believe it's a separate one altogether, there are EKG tips, tricks, resources. There's a simple nursing video, there's some practice strips, there's a practice PowerPoint, there's even a website, a link to a website where you can do some practice, where you can look at everything and kind of test your knowledge and kind of make a game out of it. The more different types of rhythm strips you can look at, right? You can look at 4 normal sinus different rhythms on different formats, on different colored paper, and they're all going to look a little different, right? So the more times you are able to look at something and practice counting it, right? Because AFib doesn't look like AFib, doesn't look like AFib, but it all falls under the same category. So lots of practice, lots of resources, and we're going to go over this more until you feel more comfortable with it.